and get started. I don't know, oh, great. Background music is off. So I just have a few announcements. I'm Greg Lewis from Mass General in Boston, and I am going to start with some moderator notes here, which is just to thank American Regent for their independent educational grant to support this activity this afternoon. I also want to thank Vox Media for program management services for this meeting. It is being sponsored by Postgraduate Healthcare Education, LLC, and PowerPack. And there's a questionnaire that all of you have received. We'd appreciate it if you could go ahead and fill that out now. There's some questions about iron in heart failure that we'd like you to answer. You can see that the slides that are circulating has the QR code for CME credits for this course. And we're going to be distributing question cards. We very much welcome and want to hear your questions and are eager to answer them. We have a Q&A session at the end, so we want to hear your questions with regard to iron deficiency and heart failure. I'd like to ask everyone to put their phones and devices on silent mode. And finally, the slides will be available for download, and this program can be viewed at a later date. If I could have the introductory slides up, we'll go ahead and get started here. Great. So the first is just, as I mentioned, the QR code in terms of for CME credits. And here's the three of us. I'm actually going to have each of us can introduce ourselves. Again, I'm Greg Lewis from Mass General in Boston. I oversee our heart failure program. Oh, great, thank you. And my interest in iron deficiency and heart failure really stems from taking care of patients who oftentimes have major functional limitations that are not adequately addressed by the medications that we currently have approved, primarily on the basis of improving outcomes in heart failure. And so that interest in iron deficiency stems from an interest in trying to find ways to help people function and feel better who are living with heart failure. We're fortunate to be joined today by Dr. Malhotra and Dr. Gale. So go ahead and introduce yourselves.
Hi, everybody. I'm Stormy Gale. I am a clinical pharmacist practitioner at Novant Heart and Vascular in Charlotte, North Carolina, and have had a lot of experience with trying to implement the diagnosis and management of patients with iron deficiency, both on the inpatient and the outpatient setting, and from more of a pharmacist perspective.
And hi, everyone. My name is Raj Malhotra. I'm a cardiologist at Massachusetts General Hospital, working alongside Dr. Lewis. And I'm interested in iron both clinically in our heart failure population as well as from a basic biology perspective, where we study the mechanisms of iron regulation in the body and how it affects cardiovascular diseases.
Okay, great. And so we'll have a series of didactic talks, and then we'll have time for Q&A. If we could just advance to the next slide, I'll go over the content of the lectures. Great. And so we're going to be starting off with Dr. Malhotra, who will talk to us about recognition of deleterious consequences of iron deficiency with or without anemia in heart failure. Then I will speak about the role of, or lack thereof, of oral iron therapy in heart failure, as well as evidence for intravenous iron therapy in the treatment of heart failure. And then finally, Dr. Gale will talk about the algorithm that we recently published in a Heart Failure Society of America scientific statement for the management of iron deficiency in heart failure, and share some of her experience in this domain as well. So we'll go ahead and get things started with Dr. Malhotra.
Thank you.
Here's your clicker. Yeah, there's one up there too.
Okay, here we go. Okay. So again, thank you, everyone. It's a privilege to be presenting here, and I would also like to echo Dr. Lewis's comments and thank America Regent and Vox Media for supporting this. I'm going to talk about the underlying pathophysiology, clinical manifestations, and diagnosis of iron deficiency in heart failure. These are my disclosures, none of which have anything to do with the topic of this talk. Okay, so the outline of my talk is that first I would like to go over the physiologic role of iron in cardiac function and how iron homeostasis is regulated in the body. And then we'll move into the epidemiology of iron deficiency and heart failure. How do we diagnose iron deficiency in heart failure, and what are the clinical implications of iron deficiency in heart failure? And we'll see that the preponderance of the data clinically in the heart failure population focuses on the HFrEF population, and so there's unmet need for studying iron deficiency in HFpEF. So what is the role of iron in cardiac function? And as you can see, and I don't know if there's a laser pointer, but as you can see, there's a multi-fold aspect of the role of iron in cardiac function. If you look at the bottom of your screen, one of the tests that we use to determine long-term prognosis in patients with heart failure is the cardiopulmonary exercise test. And the gold standard measurement of exercise capacity in this patient population is peak VO2 or peak oxygen consumption. And when we think about the equation for peak VO2, it's really the product of the amount of oxygen that's delivered to the peripheral muscles that are exercising times the cardiac output. And each one of these components of the equation are dependent on your iron status. So for instance, in order to get iron to the peripheral tissues, hemoglobin is the oxygen-carrying protein in the blood, in the red blood cells. And we all know that heme has iron on it, and that enables the heme to carry the oxygen to the peripheral tissues. So the oxygen delivery is dependent on iron status. And then what about the oxygen utilization? On the right-hand side of the screen, you'll see that myoglobin is a protein that's in our skeletal muscles and cardiac myocytes, and it will extract the oxygen from the hemoglobin to the peripheral tissues so that the skeletal muscles can use it. And myoglobin also has the iron on heme in order to bind to oxygen. And then the mitochondrial function is also highly dependent on these iron-sulfur clusters. And it's in the mitochondria that oxygen is utilized as the end acceptor of electrons in the electron transport chain that ultimately makes the ATP that we use for exercise. And so both oxygen delivery and oxygen utilization are highly dependent on your iron status and are affected in a negative way by iron deficiency. Cardiac myocyte integrity is also highly dependent on intact mitochondrial function. And so in the context of iron deficiency, you can see a depression of mitochondrial function and cardiac myocyte function. So there are many iron-containing proteins that are also altered in the state of heart failure. Hemoglobin, myoglobin, and the mitochondrial enzymes, the oxidative enzymes and respiratory chain proteins, are all highly dependent on iron. And interestingly, not only are they dependent on iron, but in the context of heart failure, these proteins are downregulated or have decreased expression, which makes it even harder for the body to have appropriate cardiac function. And so it's even more important in this context of heart failure to have adequate iron stores so that whatever proteins are available for mitochondrial function and hemoglobin and myoglobin oxygen carrying capacity, that the iron is available for that. So let's review iron overall. Iron is the most abundant trace element in the body. There's 3 to 5 grams present, and the daily recommended iron intake is 8 to 18 milligrams. It's absorbed in the first part of the small intestine, the duodenum, via ferroportin channels, and the iron is required for red blood cell production. Red blood cell lifespan is about 120 days, and at the end of that lifespan, the red blood cell will be engulfed or efferocytosed by reticuloendothelial macrophages in the blood, in the spleen, and then the iron has to be recycled by transporting the iron out of the macrophage into the ferroportin. So I did want to spend a little bit of time going over the iron homeostasis in the body and the underlying biology, because I think by spending a few minutes here, it'll make sense what our readouts are for iron when we're diagnosing iron deficiency and what our targets for therapy are. So on the left-hand side, you can see that first we take in iron in our diet, and that iron is absorbed in the small intestine through this ferroportin channel. That's the only way that you can get iron into the blood from our diet in the GI tract. So the iron has to be absorbed through this ferroportin channel, and that then enables the iron to get into the bloodstream and bind to a protein known as transferrin. Okay? That transferrin iron is then utilized by different pools. So the most of the iron is used on the bottom right-hand side by making new red blood cells in the bone marrow. Okay? Some of that iron is also used by highly energetic organs and tissues, such as heart and skeletal muscle as well. Okay? When the red blood cells reach their end of their life at 120 days, these red blood cells, if you look at the upper right-hand panel, are taken up by these macrophages, particularly in the spleen. Okay? The iron is then trapped in the macrophages until the iron can be transported out and recycled through these ferroportin channels back into the blood. So basically, ferroportin enables the recycling of iron from our macrophages and our red blood cells, and also enables the absorption of iron in our diet. Now, what regulates ferroportin channels? Actually interesting that the liver makes an enzyme, a protein known as hepcidin, that degrades ferroportin. And so when hepcidin degrades the ferroportin, not only are we not able to absorb iron in our GI system anymore, so we're overall going to become iron deficient, but where is our iron located? It's going to get trapped in the macrophages because the ferroportin in the macrophages are also broken down by hepcidin. Okay. Now, what is the teleologic reason for having hepcidin? Well, the thought is that, before the era of antibiotics, hepcidin, many bacteria use iron as a cofactor for bacterial growth and proliferation. And so hepcidin, by limiting the amount of serum iron, could improve our ability to overcome bacterial infections. So that's sort of the reason why hepcidin probably evolved in our biologic systems. But today, in the setting of antibiotics, we don't need as much hepcidin. Now, and it becomes problematic when you do have high hepcidin levels, and inflammation is one of the biggest inducers of hepcidin and can lead to anemia of chronic inflammation, hence the name anemia of chronic inflammation. Now, last thing about this slide is what are our readouts for iron? So we focus on the amount of iron in the circulation, and that's serum iron and transferrin saturation. But we also have ferritin, which is commonly used as a readout of iron, and that's actually a measure of tissue iron. Ferritin is a protein in the tissue that is upregulated in the context of increased tissue iron. But the limitation of using ferritin as a measure of iron in the tissues is that it's also an acute phase reactant. So ferritin levels will go up in the context of acute inflammatory states. And so its levels can be misleading at times. At the bottom, you can see that there's another measure called soluble transferrin receptor, which is a great measure. It's in investigation right now as a measure for the amount of cellular iron avidity that a cell has. And so it's being used in research purposes to identify states of cellular deficiency of iron. So then, how do we define iron deficiency? So if we think about it, iron deficiency is really a condition in which the iron availability is insufficient to meet the body's needs. And it can be present both in the presence or absence of anemia. So that's going to be an important point in our heart failure population is what is the role of anemia in risk stratifying our patients with iron deficiency? Patients can become iron deficient in three different mechanisms, right? Decreased iron intake, so we got to think about it in our vegetarian populations or patients who avoid red meat. Decreased iron absorption, so patients with heart failure will often have increased levels of edema that can cause gut edema and reduce iron absorption in the gut. But also because of the inflammatory component of heart failure, there's increased levels of hepcidin that can result in reduced iron absorption in the GI tract. And then we also have to worry about increased iron loss. Many of our cardiovascular patients are on blood thinners, which increases the risk for GI bleeding. Now, what are the typical measures that we use to diagnose iron deficiency in our heart failure population? Serum iron, transferrin saturation, which again is our measures of circulating iron, as well as serum ferritin, which is a measure of tissue iron, with the caveat that it is also an acute phase reactant. And hepcidin and soluble transferrin receptor are measures that are under investigation currently. There are actually two forms of iron deficiency. There's absolute iron deficiency and functional iron deficiency. And knowing the underlying biology in the previous slide will lead us to what the differences are with absolute iron deficiency. So in absolute iron deficiency, you have a real deficit in total body iron. So you're not getting enough iron in your entire body. And so not only are circulating iron levels low, but also tissue iron levels are low, meaning that transferrin saturation and ferritin are both low. Okay. Now, functional iron deficiency is not necessarily that the total body iron stores are low, it's that the iron isn't getting to where it needs to be into the serum to make red blood cells, that the iron is getting trapped in the macrophages. And so, so total iron stores are normal, but serum iron is low. And so the way we diagnose functional iron deficiency is that we have a normal ferritin, meaning a normal tissue iron, but a low serum iron or transferrin saturation. And typically this is, again, in the context of a high hepcidin level. Risk factors for iron deficiency are female sex, the more advanced your heart failure are, as well as high degrees of inflammation as evidenced by higher CRP levels. So if we put it all together, what are the clinical implications of iron deficiency in heart failure? The heart failure can induce different states of iron deficiency. The inflammation on the one side can cause functional iron deficiency through the activation of hepcidin, but reduced iron intake, reduced iron absorption, and blood loss, possibly through medication side effects, can result in an absolute iron deficiency. Either way, this results in reductions in the availability of serum iron and reductions in mitochondrial function, the ability to store and transport oxygen, impaired cellular energetics, impaired red blood cell synthesis, as well as impaired reactive oxygen species metabolism. And this can result in patients having reduced aerobic capacity, reduced endurance on exercise, fatigue, impaired quality of life, and worsening prognosis. All the things that patients complain about, with heart failure, not able to exercise as much, they're not able to move around as much without getting short of breath. A lot of this can potentially be reversed or treated with replenishment of iron deficiency. So how do we define specifically iron deficiency in heart failure? And the most commonly used definition on the top right there is a ferritin less than 100, which would signify absolute iron deficiency. Or if the ferritin is normal between a range of 100 and 299, a transferrin saturation less than 20%, which means that you have functional iron deficiency, that the iron is appropriately in the tissue but not getting into the serum. And so this is the definition that has been used in clinical trials. It's convenient to measure these ferritin and transferrin saturation with standardized blood tests. And in clinical trials, as Dr. Lewis will be going over, this definition has been used to show improvements in functional capacity. However, the gold standard definition is actually to take bone marrow aspirates and stain for iron. And so if we look at how well ferritin and transferrin saturation, this definition is, it corresponds with the actual gold standard bone marrow definition of iron deficiency. We can see that it's actually the circulating measures of iron that show a better performance with a transferrin saturation less than 20% or a serum iron less than 13. Compared to the more common definition in the clinical trials, which incorporates ferritin, which had a reduced sensitivity and specificity against the gold standard. And this is further evidence on the right-hand side of the slide, where it might be a little bit difficult to see, but basically what this study is showing in a cohort of patients with heart failure is that 5-year mortality is better predicted by just transferrin saturation less than 20% or serum iron less than 13 as compared to the guideline-based criteria that incorporates ferritin. Okay? So maybe alluding to the possibility that it's the circulating iron that's more important than the tissue iron. Okay. So what about iron deficiency and its association with anemia in heart failure? So we define, the anemia is defined by the World Health Organization as a hemoglobin less than 12 in women or less than 13 in men. And the prevalence of anemia in heart failure is similar to that of iron deficiency. It's about half of the population of heart failure is anemic. But iron deficiency typically comes before anemia when someone is iron deficient. And iron deficiency anemia, the anemia is actually more of a late stage manifestation of iron deficiency. And so a large percentage of our heart failure patients, 25 to 42%, will have iron deficiency in the absence of anemia. And you can see that on the graph on the bottom left there. You can see that, first of all, this is stratified based on New York Heart Association Class 1 going to Class 4. And you could see that, New York Heart Association Class 1, only 50% of patients have no anemia and no iron deficiency. And that number worsens down to about 30% in New York Heart Association Class 4. Okay? So as the heart failure severity worsens, patients get more iron deficient and more anemic. Okay? And when you look at the causes of anemia, only a few patients have anemia that are not related to iron deficiency. That's in orange. So the patients who are anemic, which is the combination, which is the green, with iron deficiency outweighs those that are in orange that have anemia without iron deficiency. And in the yellow, there's a big chunk of patients who have iron deficiency in the absence of anemia. Now, which of these terms, iron deficiency or anemia, portends poor prognosis? So if you look at the graph on the right-hand side, you can see that in patients with anemia alone without iron deficiency, there's no prediction of worsened mortality. It's the two groups with iron deficiency, whether you're anemic or non-anemic, that have the higher mortality. So this data seems to suggest that it's more the iron deficiency rather than the anemia that's conferring the increased risk in heart failure. And for this reason, the ACC, AHA, HFSA, and the European Society both recommend routine surveillance for anemia and iron deficiency in heart failure, and to be tested for at least annually. This, to further evidence from the prior figure in the prior slide, is that across multiple subgroups, iron deficiency predicts survival in heart failure. Okay, and there are some interesting tidbits here that it looks like, if you look at the first arrow, that iron deficiency portends an even poorer prognosis in patients with more severe heart failure, New York Heart Association Class 4, than the less severe forms of heart failure. And it's maybe that there's evidence that iron deficiency portends poor prognosis in HFrEF as opposed to HFpEF, but that's data that still in equipoise and needs to be determined. So what is the clinical significance of iron deficiency in heart failure? So I'm going to just go over a few of the studies that have been published in recent times. So in this study published in JACC, studying 157 patients with HFrEF, 43% had iron deficiency with a transferrin saturation less than 20%. All of these HFrEF patients underwent cardiopulmonary exercise testing, and no surprise based on the underlying biology, those with iron deficiency had lower peak VO2s than iron replete patients. And it was a significant difference, 11.4 versus 14.9 milliliters per kilogram per minute, sort of that range where we start thinking about, getting to that range where we start thinking about advanced therapies for heart failure patients, falling below, when it falls below 12 to 14 mils per kilo per minute. Interestingly, these patients also had worse ventilatory efficiency, VEV-CO2, which is a marker of pulmonary vascular function in our heart failure patients. And it turns out that iron deficiency is a big risk factor, not only for heart failure, but also for pulmonary hypertension. And then if you look at the figures at the bottom, it's really interesting that, again, we see that in this study, iron status was associated with survival independently of anemia, and that it wasn't the anemic status that was predicting increased hazard rates for mortality in HFrEF, but it was actually the iron deficiency that was associated with increased mortality, a threefold greater risk of death, regardless of anemia status. In this study at the top, from our colleagues in Europe, 443 patients also with stable HFrEF, so a similar population to the patient studied in the prior study. Again, iron deficiency based on the current guidelines with a ferritin less than 100 or a ferritin between 100 and 299 with a TSAT less than 20%. In this cohort, again, there was a difference in peak VO2 and ventilatory efficiency, with the iron deficient patients having a worse prognosis. But if you look at the figure at the bottom left, again, what you can see is that when we predict peak VO2, it's iron deficiency that's the predictor of peak VO2, not anemia. And when you look at the interaction between the two, the interaction of iron deficiency and anemia, there's no interaction, meaning that iron deficiency predicts worse peak VO2 in HFrEF regardless of what the anemia status is. If you look at the figure on the bottom right, you can see in this study of 552 patients with HFrEF, iron deficiency and increased levels of soluble transferrin receptor, which again is this novel investigational marker of increased cellular iron deficiency. The iron deficiency was associated with worse Minnesota Living with Heart Failure questionnaire status, but anemia was not. So it suggests that both iron deficiency is a driver of worse functional status and symptoms in our heart failure population. And finally, I just want to end off with this beautiful study. It's a very large study called Biostat CHF in over 2,000 individuals with worsening heart failure. And they use slightly different terminology, but about 62% of the patients had iron deficiency. Instead of calling it, in this study, absolute iron deficiency, they called it low iron storage. And functional iron deficiency was called DIU, which is defective iron utilization. But regardless, what they showed is that this was the first, one of the larger studies to look at the differences between absolute iron deficiency and functional iron deficiency. And what they found was that those with absolute iron deficiency had higher degrees of anemia and poor quality of life. Those with functional iron deficiency was associated with higher inflammatory levels, meaning the hepcidin levels were higher. Both of them were associated with impaired functional status assessed by 6-minute walk distance. But it was the absolute iron deficiency that had an increased all-cause mortality and heart failure hospitalization. There was a trend towards significance for the functional iron deficiency group, but it didn't meet statistical significance. How are we doing as healthcare providers in assessing iron deficiency in heart failure? Well, we're not doing a great job. We're not diagnosing it as often as we should be, and the patients who are getting diagnosed are undertreated. So in this study with over 10,000 admissions of heart failure, so these are the sicker, more advanced stages of heart failure, only 1.5% of patients during their hospital admission had adequate iron studies performed when it's in the guidelines to measure them. And of these, 109 patients met criteria for iron deficiency based on the guidelines, and only 1/5 of them actually got or received IV iron. So I think Stormy is going to talk about how we address these patient populations from a management perspective. So in summary, iron deficiency occurs quite frequently in heart failure, both in the presence or absence of anemia. There are different definitions of iron status that are being floated around, but the common one and the one that's currently supported by the guidelines is using a ferritin cutoff less than 100, or if the ferritin is between 100 and 299, using a transferrin saturation less than 20%. And it's the iron deficiency with or without anemia that's a negative prognostic factor in heart failure. Routine annual evaluation for iron deficiency is recommended in heart failure. And IV iron is the preferred route for treatment in heart failure patients, as Dr. Lewis is going to go over. Most studies have used IV iron sucrose or ferric carboxymaltose in their trials. I'll just say that ferric carboxymaltose has an FDA indication for heart failure, for iron deficiency specifically in the adult heart failure population with New York Heart Association class 2 or 3 with the indication to improve exercise capacity. It's up to all of us to improve the underdiagnosis and undertreatment of iron deficiency in heart failure. So thank you very much.
Okay, great. We'll wait for the next set of slides to load up. So you're going to notice there will be some repetition of some of the points made here. I think that Raj just had that was a tour de force through the pathophysiology of iron deficiency, which you'll see from these trials that I'm going to present is really important to have understanding of in order to be able to apply the evidence appropriately for our patients. So speaking of evidence, I'm going to talk about clinical evidence for intravenous iron therapy in heart failure. We just heard from Dr. Malhotra that this condition of iron deficiency in heart failure is underdiagnosed and undertreated. Let's go through the evidence. Here are disclosures. So I'm just going to have one slide on pathophysiology because it was just very nicely covered. But again, just by way of reminder, why are our patients with heart failure iron deficient in the first place? We take in about 10 milligrams a day in a typical diet. That's what's recommended for our iron intake through the diet. And only a small amount of that is absorbed. And as was very nicely mentioned, there's three main ways in which these heart failure patients that we take care of become iron deficient. They can have decreased absorption, either through the increased edema in the gut and decreased nutrient intake, the same process that makes these patients sometimes refractory to oral diuretic therapy and the need to have intravenous diuretics. They can have iron loss because we frequently use anticoagulants and antiplatelet agents in these patients. And then there's the decreased iron bioavailability because it gets trapped in the reticular endothelial system in the context of this pro-inflammatory state of heart failure with increased hepcidin levels. And so with this in mind, we took on the study by the name of Iron Out Heart Failure. It was a study that was sponsored by the NIH. And Raj and I and others worked on this along with Eugene Braunwald. And we asked this question, can we overcome some of those mechanisms that I just showed of iron deficiency by giving high-dose oral iron? And by high dose, we used oral iron polysaccharide, 150 milligrams twice a day. So that's 300 milligrams of elemental iron, or about 20 times what we have in our daily dietary intake. And then we compared that to a placebo group. And our primary endpoint was change in exercise capacity, peak oxygen uptake as measured at week 16 of the study after daily intake of oral iron or placebo. And first, starting with the iron studies, a lot of the conditions that we take care of with heart failure, we don't actually have a biomarker that we can measure in the blood, right? We give somebody an ACE inhibitor or a beta blocker. And so it's really nice to have these readouts that were just described in terms of measuring TSAT levels or measuring ferritin levels. And I'm going to contrast the Iron Out data with FAIR-HF, which is a study of intravenous iron repletion. And you can see what happened after giving this high-dose iron. We had pill counts, so we had excellent compliance with this drug. Patients were taking the medication, but you can see that their iron studies barely budged. The ferritin levels went up by 11 nanograms per ml. The transferrin saturation levels went up by 3%. And if you contrast that to the intravenous iron studies, you can see about a 20-fold higher increase in ferritin levels and a 4-fold higher change in transferrin saturation when you give intravenous iron to replete iron stores. So our endpoint of interest was change in exercise capacity, but of course we were interested in whether we could move the dial on iron studies, and the answer based on this data was predominantly no. Now we did look at subgroups in terms of those that had some increase in transferrin saturation versus those that did not, or those that had some change in their soluble transferrin receptor levels. And what we found was that there was not a relationship with congestion. We measured everybody's jugular venous pressure. We looked for edema. So this wasn't people that were not responding to oral iron because they were overtly congested. It was actually, and actually Dr. Malhotra measured all the hepcidin levels in his laboratory for this trial. It was, if you look at the higher levels going from left to right in quartiles of hepcidin, the highest quartile of hepcidin completely blocked the responsiveness to oral iron. There was no increase at all, and even the third quartile, you can see the confidence interval crosses 0 there. So we see that the hepcidin levels being high is correlated with lack of responsiveness to oral iron, and again, highlighting this pro-inflammatory state of heart failure. And then, not surprisingly, we saw that the exercise capacity did not change significantly in the context of minimal responsiveness to oral iron, as shown by the change in peak VO2 here in the oral iron versus placebo groups. So what about intravenous iron preparations? We know that we can bypass the hepcidin block of oral absorption of iron. We can bypass the effect of the hepcidin in terms of trapping the iron in the reticular endothelial system by virtue of giving the iron intravenously. And so we know from FAIR-HF, now coming up on its 15th anniversary since publication, that this was a double-blind, placebo-controlled, randomized trial of 459 patients. These patients were repleted with IV iron using the Gonzoni formula, and they received IV ferric carboxymaltose or placebo. The primary endpoints for this trial were patient global assessment scores, New York Heart Association class. And you can see the patient global assessment scores not only increased, but you can see increased by week 4 after starting intravenous iron, and then was consistently higher in the IV iron group compared to the placebo group. Similarly with NYHA class, these patients felt better, and then also 6-minute walk test was measured, Kansas City cardiomyopathy scores were measured. It's not easy to make heart failure patients be able to exercise more. We know that from lots of experience, and so the change in 6-minute walk tests were also particularly encouraging. If we look across 6 trials that were done that measured exercise capacity, as was described by Dr. Malhotra as being an important readout on iron deficiency status, you can see that the composite change in exercise capacity across these 6 studies was a more than 10% increase in exercise capacity, as measured either by 6-minute walk or by peak VO2. And if we contrast that to the other medicines that we use all the time to take care of patients with heart failure, beta blockers, SGLT2 inhibitors, ACE inhibitors, and ARNIs, you can see none of those medications impact exercise capacity in a positive manner. Very important medications improve survival, so certainly I'm not disparaging them, but they don't improve exercise capacity, which is the cardinal manifestation, the cardinal symptoms that our patients present with their heart failure. We also know that the Kansas City Cardiomyopathy Quality of Life questionnaire scores improve with ferric carboxymaltose based on a combined analysis of FAIR-HF and CONFIRM-HF studies, showing that there was a sizable improvement in KCCQ with clinically significant changes of more than 5 points. So what about outcomes? We've focused somewhat on exercise capacity, an important endpoint in patients with heart failure, but we also want to understand, is this medication safe, and is it going to change outcomes in terms of cardiovascular hospitalizations, heart failure hospitalizations, and mortality? I apologize, this is a busy slide, but I wanted to purposely put these multiple trials up next to one another because they give us complementary information about the effect of intravenous iron on outcomes. So first, we do have some outcomes data from the FAIR-HF and CONFIRM trials. The CONFIRM study was an IV iron versus placebo study that went out to 1 year. And then AFFIRM, AHF, recruited over 1,000 patients, followed them for 1 year, and importantly recruited patients from within the hospital. So these were hospitalized heart failure patients. And then finally, Ironman, which was a separate preparation, the ferric carboxymaltose preparation of IV iron, another high-dose IV iron. That trial actually had an admixture of outpatients and inpatients recruited, and notably followed patients for 2.7 years on intravenous iron. There were commonalities between these studies in terms of the patient populations. These were all reduced ejection fraction heart failure. You can see the ejection fractions in the 30s there. Average hemoglobins were around 12. The transferrin saturations across these studies were all below 20%, and ferritin levels were below 100. And a very important point to leave you with today is that this medication can be given relatively infrequently in order to have an effect on iron studies. You can see the annual amount of iron administered across all of these studies was less than 2 grams per year. Notable in that the preparations come in doses as high as 1 gram at a time. And you can see that the majority of these patients needed only 1 or 2 doses of IV iron in order to maintain iron replete status throughout the course of the follow-up for these trials. So to the right-hand part of your screen, these are the outcomes from these studies. So in AFFIRM, you can see that the relative risk of the primary endpoint of cardiovascular death or total heart failure hospitalizations was at 0.79. You can see it did cross 1.0 with a p-value of 0.059. And in Ironman, you can see that a similar relative risk of 0.82 similar p-value of just above 0.05. Both of these studies were conducted during the COVID pandemic and with a sensitivity analyses applied to the primary endpoints, excluding patients that were affected by the pandemic. The relative risks dropped below 0.80 with p-values below 0.05. So certainly if we take the totality of the evidence with exercise capacity improvements and with these outcomes results, albeit with marginal p-values, things are pointing in the right direction, certainly with the use of this IV iron strategy. So the HeartFID study was recently published. We designed this study to be conducted in over 3,000 patients, approximately half of whom were enrolled here in the US. And patients received either ferric carboxymaltose or placebo. These are patients that had reduced ejection fraction heart failure and met that common definition that was just described by Dr. Malhotra in terms of having ferritin levels below 100 or ferritin levels below 300 with a transferrin saturation less than 20%. The majority of patients who were over 50 kilos received 2 doses of 750 milligrams of ferric carboxymaltose. And you can see the primary endpoint was a hierarchical composite looking at all-cause mortality, heart failure hospitalizations. This was an outcomes trial, but the change in 6-minute walk test was a third tier of this composite if patients did not meet the first or second endpoint. Here is the baseline characteristics, which are important to spend a moment on. You can see at baseline the levels of ferritin were similar to the other studies that I've summarized. However, the transferrin saturations here were actually above 20%, 24% in the FCM arm, 23% in the placebo arm, which does differ from Ironman and from Confirm and from FAIR-HF and from Affirm. So slightly higher TSAT levels. And you can see that the total number of injections, these patients were followed out for a number of years. The cumulative dose of FCM at 1 year was 1.8 milligrams. Remember, these were being given in 750 milligram doses. So when patients returned for their 6-month visit, 82% of them that were in the FCM arm of the study did not require redosing because their iron studies demonstrated that they were in an iron replete range. There was some use of IV iron outside of the protocol. You can see 7% use in the placebo group. So these are the results of HeartFID, recently published in the New England Journal. You can see there was an absolute risk reduction in mortality numerically with 10.3% in the placebo group and 8.6% in the FCM group at the 12-month period. The total heart failure hospitalizations, 270 fewer heart failure hospitalization days, and then a very modest improvement in 6-minute walk distance, which was not the focal point of the study that was also conducted at many sites during the course of the pandemic. So these are the results. The totality of these results in that hierarchical endpoint analysis resulted in a p-value between the FCM and the placebo groups of 0.019. So less than our usual 0.05 cut point, though for a single trial filed with the FDA, the targeted p-value was less than 0.01. So if we put all this data together on outcomes with IV iron treatment, and we combine the Affirm study, which was all inpatients, the Confirm study, which was all outpatients, and HeartFID, which was our largest study to date, you can see that in over 4,000 patients, the primary endpoints of this meta-analysis, total cardiovascular hospitalizations and CV death, and then total heart failure hospitalizations and CV death, you can see where the relative risks are in that 0.86, 0.87 range and favoring the use of IV iron compared to placebo, albeit with p-values that are still kind of hovering around that 0.05 range. Interestingly, we heard the nice talk by Raj about the different types of markers of iron deficiency. If we look at transferrin saturation in particular, where it's not subjected to that potential confounding of being an acute phase reactant like ferritin is, you can see the lower your transferrin saturation is, if you're in that category of being less than 15%, then you're at a relative risk of 0.72 across these meta-analyses. So certainly in clinical practice, I pay a lot of attention to transferrin saturation in terms of thinking about patients who I really want to get their iron levels repleted. Safety, these newer preparations, I think many of us probably recall the days where we were only using iron dextran, which requires a test dose, has a warning about potential anaphylactic reactions. That is not the case for these newer preparations. It's been shown to be quite safe across a meta-analysis of 103 trials, not associated with increased adverse events. Anaphylaxis has become exceedingly rare. There's no test dose required for the newer IV iron preparations. And then finally, an unmet need really is a lot of the data that I've presented to you this morning is really with a reduced ejection fraction heart failure. And we need to also look at our patients with heart failure preserved ejection fraction. Shown in gray and blue are the percentage of people who meet the definition of iron deficiency if you look across a single cohort across heart failure reduced EF, mid-range EF, and preserved EF. And you can see in both of these studies that the preserved EF population, if anything, had a higher rates of iron deficiency than those with reduced ejection fraction. So Raj and I are conducting the Iron Met trial right now, which is going to enroll a total of 66 patients with a primary endpoint of change in peak VO2 with a 2-to-1 randomization of IV iron repletion versus placebo, and we're about 2/3 the way enrolled in this study at MGH. So I'll conclude my remarks. We have one more lecture, and then we'll get into the Q&A session. We do really want to hear your questions, questions about these trials I just presented, questions about clinical practice, and I think you'll find that Stormy will give us some very practical tips about iron deficiency. Thank you.
All right, while I wait for these slides to get pulled up, I think at this point we have a really good understanding of the pathophysiology of iron deficiency and heart failure. We have an understanding of how to diagnose iron deficiency and heart failure and the potential benefits that we see with IV iron repletion. So the question really becomes, how do we get this done in practice, especially when a lot of our cardiologists are used to using oral medications and certainly not as many IV medications on the outpatient side. It becomes a little bit more complicated than some of our other therapies. I have no disclosures related to this presentation. So what we're going to do is really just walk through a patient case or two and kind of look at our guidelines and see what we would do for this patient. So we have a 71-year-old, 70-kilo man. He has heart failure with reduced ejection fraction. His EF is 25 to 30%. He goes to his primary care physician for routine follow-up, complaining over the last several months that he's just tiring more quickly on his daily walks, so very common reduction in exercise capacity that we see in these patients. He appears well perfused and euvolemic on exam, and labs drawn prior to his visit demonstrate a hemoglobin of 13.8. And so we don't have audience response here, but I just want you to sort of think in your own minds or even talk to your neighbor if you would order an iron panel in this patient. So kind of I'll walk through the things that I'm thinking about as you're thinking as well. So we have a patient who has heart failure with reduced ejection fraction. He has some symptoms that are pretty standard for patients who have iron deficiency and heart failure with that reduced exercise capacity. And we do have a hemoglobin, and interestingly, this hemoglobin is not low, so this patient does not have anemia. So is an iron panel indicated here? So as we walk through this case, we're going to use the algorithm that we created for the HFSA scientific statement, because I think this is sort of an easy way to think about our patients in terms of diagnosis and management. So the first thing we want to know is, does the patient even need an iron panel? Well, we have a symptomatic patient. We've established that. He has at least a mildly reduced, if not reduced, ejection fraction, which, as we know, is where the bulk of the evidence is right now, and hopefully we'll have more evidence soon in our HFpEF population. And he has a hemoglobin less than 15. And I'll point this out because as Dr. Malhotra pointed out earlier, it is very common, up to 40% even of patients who have iron deficiency don't have concomitant anemia. And so just because this patient's hemoglobin is normal does not mean that we don't want to check an iron panel in him. But we don't have a ton of evidence for repleting iron in patients with higher hemoglobins greater than 15. And so the risk there is really, do we increase blood viscosity to a point where we could cause adverse effects? And we don't really know the answer to that question, at least not in large randomized trials. So we want to see if this patient needs an iron panel. Now, just for the sake of completeness, if he had severe life-threatening anemia, we of course would want to evaluate the etiologies of that and transfuse as needed. But he doesn't, and so we're going to obtain iron studies. So our iron panel is ordered, and it reveals a transferrin saturation of 15% and a ferritin of 106. And I'll just point out, it's very easy to get iron panels and fairly inexpensive. So it costs about $10 in a green top tube, which is the same tube that we use for a BMP. And so in the inpatient setting, certainly all of our patients are getting constant BMPs. In the outpatient setting, we're getting them relatively often to monitor their therapies. So this is something that can easily be added on to labs that are already being drawn and doesn't necessarily need an extra stick for patients. So we see a transferrin saturation of 15% and a ferritin of 106. So getting back to our standard definition, and we know there's some criticism of this definition, and we may see changes to it in the future, but for now, this is what most of our studies have utilized. This patient's ferritin is between 100 and 300 with a transferrin saturation less than 20%. And especially because this patient's transferrin saturation is less than 20%, he's a really good candidate here for IV iron. So let's go back to the patient case and remind us who the patient is. So we have the 71-year-old. He's 72 kilos with HFrEF. He's tiring more quickly on his daily walks. He has a normal hemoglobin, but he does have iron deficiency, which we just established. So what would be the optimal treatment here of this patient's iron deficiency? And we've already heard a wonderful talk about the benefits of IV iron. So certainly we're going to consider IV iron for this patient. And so when we decide what to do with our IV iron, it really depends on, are we in an inpatient or an outpatient setting? And here, this patient's presenting in an ambulatory clinic, so we're in an outpatient setting. We're going to want to coordinate a plan for outpatient IV iron to replete his total deficit. Now, importantly, there's a little bit of a change on this slide compared to what you'll see on the actual algorithm that's published, where there's discussion of the Ganzoni equation, and we're going to talk a little bit more about that on this slide here. So I think the most, by far, common question I get asked from providers and other pharmacists is about the dosing of iron and how much iron should these patients get. And it's very complicated when you look at all of the data, but there's a really easy way to simplify it. So that's what we're going to try to do. Our early studies of heart failure really calculated patient-specific deficits using the Ganzoni formula, which is there for you on that slide, but really it's just a way to calculate these deficits based on weight and hemoglobin. But there's unclear accuracy of this equation in heart failure, and it might put a little bit too much emphasis on hemoglobin. We know that hemoglobin patients will benefit from IV iron regardless of whether or not their hemoglobin is low. So our most recent studies have moved away from Ganzoni equation and really have used these nomograms that still take into account weight and hemoglobin and give a range of anywhere from 500 to 2,000 milligrams, initially with the option to re-replete within the next several months to years, depending on if the patient is still deficient. I don't really want us to get bogged down in the first 3 studies here because there's different ranges depending on patient-specific factors. What I really want to focus on is the last study, and Dr. Lewis did a great job of going through what HeartFit found and how they did their study. And so you can see they did the 750 milligram flat dosing on day 0 and 7, or if patients weighed less than 50 kilos, they used 15 milligrams per kilogram. And this is really what I've started using in my practice because I think it's just a lot easier for everyone than trying to calculate these patient-specific deficits. But I'll show your attention to the right-hand side of the slide under cumulative dose. And so this is the dosing that was required either initially or in the first year of these studies. And you can see in Confirm, it was 1,500 milligrams, Affirm 1,400, Ironman almost 2 grams, and HeartFit 1,809. And so I point that out because I don't even often see IV iron being ordered because it's very under-optimized. But when I do see it ordered, I feel like it's very common for us to be underdosing patients, where I'm seeing either a gram or less in many of my patients. Where you can see here that a lot of patients are requiring higher doses, and our meta-analyses show that less than 1 in 5 patients will require more than 1,500 milligrams. So for that reason, for me, 1,500 milligrams is a very easy and reasonable initial dose for most of our patients, and it doesn't have so much that we have to think about, unless they weigh less than 50 kilos, in which case we can do weight-based dosing. So the other thing that we have to consider for this patient, because we're in the outpatient setting, is where do we do our repletion? And this really depends on your institution. So I would say most institutions, including my own, historically have used infusion centers to do their IV iron. But there's many that have started to develop IV iron clinics where a patient can get this done in clinic, or some have tried to get really creative with this and do this in an observation unit or even pre or post procedure. So there's a couple different ways you can do this, but in general, there's still a lot that we have to think about. So one, we know that our infusion centers are very busy and they may or may not have much space and chair availability. So how often the patient's coming in and how long they're gonna tie up a chair can be important to know. And we sometimes have times when our infusion center will put extra emphasis on those that are getting those drugs that are getting bigger margins of reimbursements, like some of our cancer therapies. You can try to leverage your 340B pricing if you have a hospital-based infusion center. We have to think about nursing support and sterile compounding. You know, this is already sort of in part of the infrastructure for the infusion center, but if you're trying to create a program in a clinic or in an observation unit, you not only need to make sure that you have the staff there to do this, but that they're also trained for the administration and the monitoring that's required for IV iron therapy. And then I think a lot of us don't realize, and a lot of providers don't realize, what happens when they put in an order for IV iron, that a lot of times our infusion centers have an access team with pharmacy technicians. And so these technicians are ensuring that these agents are covered before the patient ever even gets scheduled for the infusion. And so that's part of the infusion center infrastructure, but if you're going to create something in a clinic or an observation unit, you certainly want to make sure that you're getting reimbursed appropriately for those agents. And then, as Dr. Lewis mentioned, these agents have been shown over and over again to be very, very safe, but we still have the small chance of some sort of reaction. And so we want to make sure that we have protocols in place for those. Although I will say that most of the hypersensitivity reactions with IV iron can be solved by just slowing down the infusion rate. So how do we determine our formulation? There's many different formulations available, and we know that they differ with a lot of different things. So how long they've been available, how much they cost, how much you can give at one time. Of course, there are evidence in patients with heart failure, where by far ferric carboxymaltose right now has the bulk of the evidence in large randomized controlled trials and is the only that is currently FDA approved. But you can see that this becomes complicated when we're thinking about outpatient repletion, because if I want to give a patient 1,500 milligrams and my only option is iron sucrose, well, I have to tell this patient they need to come to my infusion center 7 to 8 times to get their full repletion. And for those of you who are patient-facing, we know that patients don't really love to hear that from us. So that can make things a little bit more complicated than they need to be. So I do want to walk through the dosing for ferric carboxymaltose, specifically the FDA-approved label for it. Of course, this is the only FDA-approved agent, and so it's the only agent right now that has labeled dosing for the indication of heart failure. And so we'll walk through what this will look like in our specific patient. So they have one of these nomograms that uses weight and hemoglobin. So as a reminder at the bottom there, you see our patient weighed 72 kilos with a hemoglobin of 13.8. And so I'd say this is probably the most common area where patients are going to fall into. So between a hemoglobin between 10 and 14, less than 70 kilos, on day 1, they get 1,000 milligrams, and on week 6, they get 500 milligrams. So a total of 1,500 milligrams, 6 weeks apart. And so I mentioned earlier, this isn't necessarily the dosing that I use in practice, and I'll tell you why. So we know from HeartFid that we can safely use a 1,500 milligram flat dose. So that's easier than using this nomogram. They're still giving 1,500 milligrams to this patient. We're getting it done within a week, not having to wait 6 weeks to get our repletion completed. And then the other thing is that ferric carboxymaltose comes in 750 milligram vials. So let's use that as an example for our patient. Our dose on day 1, we're going to use 2 vials and waste some for that dose. And then when they come back 6 weeks later, we're going to use another vial and waste a little bit for the third dose. So we're using 3 vials and wasting some of our ferric carboxymaltose, when if we use the dosing from HeartFid, we use 2 vials, we save a vial, and we don't waste any. And we get the patient repleted faster. And we didn't have to look at this nomogram to figure out what dose we were going to do. So I think using HeartFid really just makes sense from a safety standpoint, from a waste standpoint, and just from ease for your providers and for your pharmacists. So with that, we'll move into our case in the inpatient setting. So it's very common that we see patients coming into the hospital for decompensated heart failure. We have LC here. Her ejection fraction is 25%. She started on a furosemide drip. And her labs show a hemoglobin of 13. Her ferritin is 260, and transferrin saturation is 12%. See, her blood pressure is 108/68, heart rate 88 beats per minute, and weight is 77 kilos. So the question becomes, is there a role for IV iron in this patient? So things we think about, right? Does she meet criteria for iron deficiency? Well, her ferritin's between 1 and 300, and her transferrin saturation is less than 20%. So she meets criteria for iron deficiency. Her hemoglobin is less than 13, and by definition, all of our patients who are coming in with decompensated heart failure are symptomatic. So she's meeting our criteria for getting IV iron repletion. So if we're doing this on the inpatient side, we want to make sure that we administer to try to replete the total deficit as much as possible before the patient is discharged. And we know from our lots of data with guideline-directed medical therapy that if we don't do things in the hospital, they tend not to get done once patients leave. So as much as we can do before they leave is going to be important. So of course, outpatient, as we discussed, is a little bit more complicated. We have an outpatient formulary that we have to follow. We have to make sure it's covered by the patient's insurance, and we have to think about the schedule and all the barriers that the patients have for getting to their appointments. The inpatient side is a lot easier, so we can use whatever is on our inpatient formulary. We can consider things like cost and our ability to replete prior to discharge. So as an example, even if we have some agents other than ferric carboxymaltose, so for example, my institution has sodium ferric gluconate on formulary, there is data for the safety of doing accelerated regimens of these older formulations for patients with heart failure, where you can do a 250 milligram dose twice a day for repletion. And we know that the average hospital stay for patients with heart failure is around 3 to 5 days. And so with a 3-day stay, you can get a 1,500 milligram repletion using one of these less expensive agents. So now we're going to think about what are ways that we can improve the diagnosis and management of iron deficiency in heart failure. As Dr. Malhotra mentioned earlier, ID in heart failure is very, very under-recognized. We have class 1 recommendations for this, and yet it's not really treated like a class 1 recommendation in practice. You know, up to 80% with decompensated heart failure have concomitant iron deficiency, and there's a lot of providers that just aren't aware of anything about the etiology of iron deficiency in heart failure, how common it is, or how to manage it. And we oftentimes only are getting iron panels when we see patients are anemic. So we can implement tools within the electronic health record to try to improve our diagnosis and management of ID in heart failure. So some of the ways that this has been done, there's a lot of publications out there for ways to improve screening and diagnosis. You know, one way most of us as institutions have heart failure order sets for patients who are getting admitted with heart failure. So those order sets typically have labs on them. If we go ahead and add iron panels if they haven't been done in the last 3 to 6 months, that can be really helpful. We can consider alerts. You see on the right-hand side, this is a publication that implemented an alert in Cerner so that they would tell providers if they wanted to order iron panels. Of course, we have to be careful about alerts because alert fatigue is a real thing, and so we can't necessarily alert our providers about everything. And then we want to make sure that when we do find iron deficiency, that these patients are getting optimally managed. So even leveraging our order sets so that they're already built in a way that uses our institutional formulations and has dosing that's consistent with what is needed in patients with heart failure. To have ways to have additional guidance and decision support on there, particularly to let people know if the labs are actually iron deficiency in heart failure. And then there's been a couple of publications as well that have looked into options for a consult, and so that can be a consult to pharmacists to evaluate patients for IV iron therapy and to either order or pend orders for IV iron to make sure that that's getting done appropriately. So in summary, patients with heart failure with reduced and mildly reduced ejection fraction should be evaluated for iron deficiency, and they should be repleted with IV iron if they're deficient. To me, an initial dose of 1,500 milligrams is reasonable for most of our patients unless they have really low body weight. Iron formulation should really be selected based on our formulary preferences, whatever we have available, and also this convenience for patients, particularly in the outpatient setting. And we should really be considering IV iron in all of our patients who are admitted with heart failure if they have iron deficiency and trying to replete them prior to discharge. And we should try to leverage our technology to improve the diagnosis and management of this population. Thank you all for your attention. I know we look forward to our discussion.
All right, great. Well, we're starting to get some questions coming in. These are terrific questions, so please feel free to submit the cards. You can come up and ask the questions directly as well. We'll get started. I can certainly take on the first one. So this was from Dr. Malhotra's talk, 2019, and obviously my colleagues will weigh in on this as well. 1.5% of patients had adequate iron studies performed. Now in 2024, very relevant, 5 years later, with the HFSA guidelines, has the performance changed? And if so, what is the percentage? So it's a great question, and we can all kind of weigh in on this a bit. We've actually been looking at this within our health system, which combines predominantly academic medical centers, Mass General, Brigham and Women's Hospital, but also some additional health centers in the Massachusetts area. And we looked at this across a period of essentially 2012, 2017, and then 2022, just in terms of having all the data available. And what we're seeing is, yes, there is an increment in the percentage of patients getting iron studies done. That percentage remains well below 50%. And when we look at like the 2022 era, unfortunately, it's confounded by the fact that lots of patients were coming in with COVID, right? And so they had their ferritin levels checked for alternative reasons, and that has to be kind of disentangled a bit. So we're seeing within our health system, still less than half of patients are getting the appropriate iron studies done when they're coming into the hospital, and within a period of an entire year. So we thought that was a reasonable kind of a way to bracket things. And then those that are getting their iron studies checked, there's a even smaller percentage of people that are actually getting treated with intravenous iron. The percentage getting intravenous iron has increased, but somewhat embarrassingly, the use of oral iron remains higher percentage-wise than the use of IV iron within our health system. IV iron is rapidly catching up. It was like a 95 to 5% 10 years ago. Now it's about 50-50. So still, 55-45. About 55% of people are still getting treated with oral iron heart failure patients, and about 45% are getting IV iron preparation. So we are certainly seeing a ramp up in the ascertainment of iron status, as well as in the use of iron repletion. But that's an example at a academic medical center where there's people like Dr. Malhotra and I going around talking about iron. So I think we have a lot of work to do. Hopefully that answers the question to some extent. And then do either of you want to weigh in on?
I'll just say that I work in a large community health system, and we did a similar evaluation, a medication use evaluation, to see what we were doing in our inpatients with iron, and our numbers were just dismal. So, way less than half of patients getting iron panels, and very, very low numbers that were getting repletion. Also with me constantly nagging people to do so. So I think, there's just a lot of progress to be made in that area, and I think some of the things that we talked about with leveraging our technology so that there's just more awareness and less having to think about it would be helpful.
Go ahead, Raj. I don't have too much more to add other than despite the change in the guidelines or the updates in the guidelines, certainly we still have a long way to go of measuring iron levels annually in our heart failure population. There's still equipoise in the HFrEF population, but even in the HFrEF population, we're seeing that under 20% are being assessed annually in recent times. Should I move on to this question?
Yep.
So there's a question here. Are hepcidin blockers something under development? IV iron clearly works well at increasing iron, but there may be barriers to therapy for some. So thank you for this excellent question. Hepcidin inhibitors are being developed. There's a small molecule antagonist of hepcidin that's currently under phase 2 studies. So that's the one that's most farthest along in terms of development. And hopefully we'll get some safety profiles and then even transitioning to phase 3 data in the next few years. And then there are a few companies that are testing out inhibitory RNA therapies for hepcidin. And so, the jury's still out on seeing how effective they are in human studies. So thank you. I think that, we're focused on heart failure here, but the potential for these hepcidin blockers to treat the vast array of patients with anemia of chronic inflammation, not just those with cardiovascular disease, but also patients with cancer or rheumatologic conditions, you can potentially have a large impact for our patients.
And I think it's safe to say that with regard to the, I hope we left you with some increased appreciation for the role of hepcidin in terms of in the pathophysiology of the development of iron deficiency and heart failure. I think as all of us emphasize, we're still learning about the optimal way to apply the different biochemical tests. The great news is that we can add on iron studies, as Stormy said, when we're doing a basic metabolic panel. At our institution, they cost less than $10 to run, and it's from the same blood tube that you get your potassium and your BUN and creatinine from. And so I think that we should be able to move the dial on the proportion of people getting iron studies. We're still in the process of understanding the optimal way to interpret the iron studies, particularly as it relates to ferritin. I think the preponderance of evidence suggests that when that transferrin saturation level is low, that is a patient population that should be targeted. It's low in functional iron deficiency, it's low in absolute iron deficiency, and so that's a population that should really be targeted. Interestingly, as Raj mentioned in his talk, the majority of our ferritin resides intracellularly, such that the ferritin levels that we measure in the bloodstream represent about 1/1000th of the total amount of ferritin in the body is actually circulating. And you could imagine if that's under the regulation of things like interleukin-6 and pro-inflammatory state, such that the more inflamed you are, the more that you move that ferritin pool from intracellular out into the bloodstream. We have to be a bit careful in terms of how we interpret our ferritin levels, because a actually normal ferritin level or even a high ferritin level may not indicate that the patient actually has adequate amounts of iron in their system, but rather they're just pushing more of that ferritin out into the bloodstream by virtue of them being in this pro-inflammatory state. So I think we're still in the process of kind of optimizing how we apply the definitions. It turns out that the transferrin saturation is very easy to derive, right? If we have an iron level and we have a TIBC, it's simply iron divided by the TIBC level that comes out from your iron studies. And the iron level itself is actually less subject to the modulation by inflammation. So just looking at iron levels, either in micromolar, less than 13, or if your laboratory reports in micrograms per ml, it's going to be less than 76. And so having a low iron level is also another indicator of your iron status. So again, I think it's a real luxury to be able to monitor iron studies, and then we're only going to get, I think, better at really understanding how best to interpret and to apply them. We're happy to take additional questions. I think that Stormy nicely walked us through some of the kind of practical implications of giving iron intravenously, either in the outpatient or inpatient setting. So maybe you can talk a little bit more about these different, what are the implications of these different strategies at our institution. I know when we refer patients to the infusion center, we're oftentimes going to competing with patients that are getting, cancer therapies and other things that 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 make it sometimes challenging for us to kind of get our patients in. So would love to hear your thoughts in terms of as we look into the future, ways that we may be able to deliver what seems to be the safe therapy to our patients.
Yeah, I mean, I think you make a great point, and I think this is why we're seeing an increasing number of institutions, and even my own institution is one of them, that are trying to create clinics that specifically can address anemia in this population, or a way for in your heart failure clinic that you can administer IV iron. So, there's a couple of things you can think about. One, it depends on what agent you're using, right? Because some agents are going to tie up a chair longer than others, where some agents we can give push undiluted. And so with an agent like ferric carboxymaltose, we can give that agent over 15 minutes, or we can give it push over 15 minutes, and that way we're not tying up a chair for a long time, but we still have monitoring that we have to do after the patient receives the dose. So I think trying to get creative and working through some of our protocols and seeing if there's ways to get this done outside of an infusion center in a clinic is something that might be really helpful. We're often already giving, loop diuretics in our clinic, so this is just another injectable agent that we could maybe add to what we're able to give.
Yeah, thanks. So when I think about the loop diuretic use in clinic, right? We're giving somebody a medication that, best case scenario, will have an effect that will persist for about 24 hours or so, right? And so we give one dose of intravenous loop diuretic, and we go through all the trouble of administering that. And one of the points just to emphasize about the data is across the studies that I showed with IV iron, we're on average having to administer less than 2 grams, or I think as nicely articulated, if you do that 750 milligrams times 2, you get into that 1.5 gram range, and that is the average amount that people required in order to keep their iron studies in range over the course of some of those 12-month studies. So we're talking about administration of a therapy that can oftentimes be accomplished in terms of sufficient amount in 1 or 2 doses. And for all of us that participate in the care of these patients, we have a lot of polypharmacy. We have a lot of medications that are being taken once or twice every single day. And so at least for me as a clinician taking care of patients with heart failure, I welcome the opportunity to give a medication, once or twice over the course of a year, as opposed to some of the other medications that we're giving, that do really, require patients to take them, every single day, oftentimes, more than once a day. So I think that some of these polypharmacy considerations are important, and some of the how much time do you spend in the infusion center, how many visits do patients have to come in and out in order to get their iron therapy, are all important to consider.
And I think along those same lines, if we think about how much iron is lost intestinally every day, it's only about 1 to 3 milligrams per day. So if you've replenished someone 1,500 milligrams, that can last for well over a year, 2 years, without having to think about replenishing patients with iron deficiency who just aren't able to absorb iron in their GI system. So that's one of the advantages also of IV iron repletion, is you can get a large amount of replenishment that can last a significant amount of time.
Yeah, I agree with that. And of course, cost is always going to be an important consideration. And I know this is a managed care audience, and so certainly something that we're all thinking about. And we have differences in the cost between our different agents, and certainly our newer agents are more costly at face value than some of the older agents. Not that there's anything wrong with using any of the older agents, but when we think about the convenience and the other indirect costs, like the cost of patients tying up an infusion chair, those sorts of things, there's actually published data now within the past couple of years looking at the economic value of using IV iron in these patients, and found to be valuable. I think it saves like around $5,000 a patient when you replete them with IV iron, and this was a ferric carboxymaltose study. So there is value there from a cost perspective as well.
One thing I recognize that I think that all of you or many of you completed the questions at the beginning of the session. I don't know if we actually have those available in terms of some of our Vox Media colleagues, but we can certainly run through those at the conclusion of this session in terms of I have a feeling that the audience probably did very well on them, and I think we've covered the content. But if we have one of the questionnaires available, we can the three of us can run through the answers for them. Online, okay, great. So the online answers will be available for all of you and for those that are joining us online as well. But just from memory in terms of the considerations, Dr. Malhotra went through the prognostication data quite a bit in terms of IV iron, or in terms of iron deficiency being an independent predictor of outcomes in our patients. And then I think Stormy nicely covered the iron studies, which again, if you obtain iron and you obtain TIBC and you obtain ferritin, then the transferrin saturation can be easily derived from those three measures in terms of the answer to the other question about iron deficiency. And I think we're still learning in fairness as to the frequency of repeat measures. As has been mentioned, the majority of patients out there have not been getting IV iron repletion, right? And so I think that if somebody has iron studies done and they're kind of in a borderline category and they're quite symptomatic and you're seeing them back 3 months later, it certainly, or 6 months later, is reasonable to repeat their iron studies. It's not like there's like a lockout period, right? If you check them, you can't check them again for another year. So I think we're still learning in that domain. And similarly, if you repleted somebody with 1,500 milligrams, we might find that every time that we repeat the studies at the 3-month or 6-month point, they tend to be in range, right? And so I think we'll continue to learn more in terms of refining some of those algorithms that we put forth in the Heart Failure Society of America scientific statement in terms of how best to manage these patients longitudinally. Okay, well, I think we're right at the 1:30 point here, or I guess 1:25 on. If there's any other questions, people can certainly come forward to ask them, or you can meet us up here afterwards. I'm sure all of us would be happy to share our contact information too if there's questions that come up outside of the context of this meeting. Any closing comments?
Thanks,
Thank
Greg.
you all.
Thanks all.